A 71-year-old man named Leonard sat in my clinic 14 months ago and said something that stopped me cold. Doctor, I take my blood pressure medication every single morning. I never miss a dose. But last month I had a mini stroke at 3 a.m. How is that possible? Leonard did everything right. He took his medication faithfully. Same pill, same dose. Every single morning at 7 a.m. with his breakfast. For 9 years. He never skipped. He never forgot. He was the most compliant patient any doctor could ask for. And at 3:17 a.m. on a Tuesday morning, a blood clot formed in a narrowed artery in his brain. His wife found him struggling to speak. He spent 4 days in the hospital. When I reviewed his 24-hour ambulatory blood pressure data, the answer was painfully clear. Leonard's medication was peaking in effectiveness around noon and wearing off by midnight. Between 2 a.m. and 6 a.m., the most dangerous hours of the entire day for cardiovascular events, his blood pressure was surging completely unprotected. His pill was working, just not when he needed it most. Leonard looked at me from his hospital bed and asked, "Why didn't anyone tell me that when I take my pill matters as much as which pill I take?" I didn't have a good answer. Because he was right. I'm Dr. Arav Menon, and this is MediGentle. I've spent over 25 years in cardiovascular medicine, and today I'm going to reveal something that could fundamentally change how you manage your blood pressure. The time of day you take your medication may be as important as the medication itself. I'll walk you through the science, the studies, the risks, and the exact questions you need to ask your doctor at your next appointment. This is not a video telling you to change your medication on your own. This is a video giving you the knowledge to have a conversation that could save your life. But first, I need to explain something most patients have never been told. Your blood pressure doesn't stay the same throughout the day. It follows a hidden 24-hour rhythm. And understanding that rhythm changes everything. Before I reveal the risky timing and the optimal timing, you need to understand what your blood pressure actually does while you're not watching it. Most people check their blood pressure once or twice a day. Morning, maybe evening. They see two numbers and assume those numbers represent what's happening all the time. They don't. Your blood pressure follows a circadian rhythm, a 24-hour biological cycle controlled by your internal clock, your hormones, and your nervous system. And this rhythm has predictable peaks and valleys that directly determine when your heart is most vulnerable. Here's what that rhythm looks like. Between approximately 3 a.m. and 6 a.m., while you're still asleep, your body begins releasing cortisol and catecholamines, your stress hormones. These hormones prepare your body to wake up. They increase heart rate. They constrict blood vessels. And they cause a sharp, rapid rise in blood pressure called the morning surge. This morning surge is the most dangerous cardiovascular window of the entire 24-hour cycle. Research published in the journal Circulation has consistently shown that the incidence of heart attacks, strokes, and sudden cardiac death peaks between 6 a.m. and noon, with the highest concentration occurring in the early morning hours. This is not coincidence. It's biology. After the morning peak, blood pressure typically remains elevated through the afternoon, then gradually decreases during the evening. During deep sleep, between approximately midnight and 3 a.m., blood pressure reaches its lowest point. This nighttime drop is called nocturnal dipping. In a healthy cardiovascular system, blood pressure drops by 10 to 20% during sleep. This dip is essential. It gives your heart, arteries, and kidneys a period of rest and recovery. But here's where things become dangerous after 60. Many seniors lose their nocturnal dip. Instead of blood pressure dropping during sleep, it stays elevated or even rises. This is called a non-dipping pattern, and it's associated with significantly higher rates of heart attack, stroke, kidney damage, and cardiovascular death. A study published in the European Heart Journal found that non-dipping blood pressure patterns were an independent predictor of cardiovascular events, even after accounting for overall blood pressure levels. Meaning, Your nighttime pattern matters as much as your daytime numbers. So now the critical question becomes this: when does your medication reach its peak effectiveness? And does that peak align with when your body actually needs protection? For millions of seniors, the answer is no. Let me show you what happens when you take your blood pressure medication at 7 or 8 a.m., which is what the vast majority of people do. Most common blood pressure medications, including ACE inhibitors, ARBs, calcium channel blockers, and diuretics, reach their peak plasma concentration approximately 2 to 6 hours after ingestion. That means if you take your pill at 7 a.m., it hits maximum effectiveness somewhere between 9 a.m. and 1 p.m. By 6 p.m., the drug level is declining. By midnight, it's significantly reduced. By 3 a.m., when that dangerous morning surge begins, the medication is at its lowest concentration in your bloodstream. The hours when your blood pressure is rising most aggressively are the exact hours when your pill is providing the least protection. Your medication isn't failing. It's peaking at the wrong time. Let me tell you about another patient. A 67-year-old woman named Barbara. She'd been taking amlodipine, a calcium channel blocker, every morning at 8 a.m. for 6 years. Her daytime blood pressure readings were excellent. 132 over 80. 128 over 78. Her doctor was pleased. On paper, everything looked perfect. But Barbara kept telling me she woke up with headaches. Pounding, pressure-like headaches that faded by mid-morning. Her doctor attributed them to tension, poor sleep, stress. I suspected something else. I ordered a 24-hour ambulatory blood pressure monitor. This device takes a reading every 20 to 30 minutes for an entire day and night. The results revealed what I expected. Barbara's blood pressure between 3 a.m. and 7 a.m. was averaging 162 over 96, nearly stage 2 hypertension, every single night. While her body should have been resting and recovering, her arteries were under intense pressure. Her headaches weren't tension. They were uncontrolled nighttime hypertension. Her daytime readings were fine because that's when her medication was working. But the 8 hours her doctor never measured were the 8 hours causing the most damage. I want to be very clear about something. I'm not telling you morning dosing is wrong for everyone. For some patients, for some medications, morning dosing is perfectly appropriate. What I'm telling you is that for a significant number of seniors, particularly those with non-dipping patterns, morning-only dosing leaves a dangerous gap during the most vulnerable hours. And most people will never know they have this gap unless someone specifically tests for it. A standard office blood pressure reading taken at 10 a.m. cannot tell you what's happening at 3 a.m. It's a snapshot that misses the storm. Now, let me show you what the research says about a simple timing change that has produced some of the most striking results in recent blood pressure research. In 2019, a landmark study called the Hygia chronotherapy trial was published in the European Heart Journal. It followed over 19,000 patients with hypertension for a median of more than 6 years. Patients were randomly assigned to take their blood pressure medication either in the morning or at bedtime. The results shook the cardiology world. Patients who took at least one blood pressure medication at bedtime showed significantly improved blood pressure control during sleep. Their nocturnal dipping patterns improved. And most importantly, their risk of major cardiovascular events, heart attack, stroke, heart failure, and cardiovascular death was substantially lower compared to those who took the same medication in the morning. These were not different medications. Same drugs. Same doses. The only variable was timing. Now, I need to share something important with you because MediGentle is built on honesty, not sensationalism. The Hygia trial generated significant discussion within the cardiology community. Some researchers raised questions about the study's methodology. A subsequent large trial called Time, published in The Lancet in 2022, involving over 21,000 patients in the UK, found no significant difference in cardiovascular outcomes between morning and bedtime dosing when looking at the overall population. So, which study is right? Here's what I believe the complete evidence tells us when you put both studies together with decades of chronobiology research. For the general population of hypertension patients, timing may not dramatically change outcomes. But for specific groups of seniors, bedtime dosing may offer meaningful advantages. Those groups include non-dippers, people whose blood pressure doesn't drop adequately during sleep, people with early morning surge patterns, whose blood pressure spikes aggressively between 3 a.m. and 6 a.m., seniors with chronic kidney disease, where nighttime blood pressure control has been consistently linked to better kidney preservation, and patients whose current morning dosing leaves their nighttime hours unprotected, exactly like Leonard and Barbara. A meta-analysis published in the journal Hypertension Research reviewing multiple chronotherapy studies concluded that bedtime dosing consistently improved nighttime blood pressure control and nocturnal dipping patterns, even when overall cardiovascular outcomes remain similar. And here's the clinical reality I've observed over 25 years. Nighttime blood pressure control is the most neglected aspect of hypertension management. Most doctors measure blood pressure during office hours, prescribe medication to be taken in the morning, and never investigate what happens during the 8 hours their patient sleeps. That 8-hour gap is where I've found the hidden damage in patient after patient. Leonard, Barbara, dozens of others. Their daytime numbers looked fine. Their nighttime numbers were silently destroying their arteries, their kidneys, and their hearts. The timing conversation isn't about proving one study right and another wrong. It's about asking a simple question that most patients never think to ask and most doctors don't have time to raise. Is my medication protecting me when I need it most? Now let me show you the 5 warning signs that suggest your medication timing might need reevaluation. Not everyone needs to change their medication timing, but certain patterns suggest you should at least have the conversation with your doctor. Here are 5 warning signs I look for in my patients. Warning sign number 1, morning headaches. If you consistently wake up with a headache that fades within an hour or two, this may not be tension or dehydration. It may be uncontrolled nighttime blood pressure. The pounding pressure-like quality is caused by elevated pressure in the blood vessels of your brain during sleep. Barbara had this for years before anyone connected it to her blood pressure pattern. Warning sign number 2. Your blood pressure is higher when measured first thing in the morning than at any other time of day. If you own a home monitor and your highest readings consistently occur within the first 30 minutes of waking, before your morning medication has had time to work, that's a strong indicator your nighttime hours are unprotected. Here's a Medigenal self-test. For 1 week, take your blood pressure 3 times daily. Immediately upon waking before taking medication, in the early afternoon, and right before bed. Write all 3 numbers down. If your morning reading is consistently 15 or more points higher than your afternoon reading, bring that log to your doctor and specifically ask about medication timing. Warning sign number 3. You wake up multiple times during the night. Uncontrolled nighttime blood pressure disrupts sleep architecture. Your body senses the elevated pressure and partially wakes you as a protective response. If you're waking 2 to 4 times per night without a clear cause like needing the bathroom, elevated nocturnal blood pressure could be a contributing factor. Warning sign number 4. Your blood pressure is well controlled during office visits, but you still experience cardiovascular symptoms. Dizziness when standing in the morning. Chest tightness in the early hours. Shortness of breath during the night. Vision changes upon waking. If your in-office numbers look good, but you're experiencing symptoms at times your doctor doesn't measure, the gap between medication effectiveness and actual need may be the explanation. Warning sign number 5. Your doctor has had to increase your medication dose more than once, but your numbers still aren't fully controlled. Sometimes the issue isn't potency. It's timing. A medication taken at the wrong time may appear inadequate, Leading the dose increases that cause side effects without solving the underlying timing mismatch. Let me ask you directly, how many of these 5 warning signs apply to you? Count them right now. Drop your number in the comments. If your answer is 2 or more, the conversation with your doctor about timing becomes genuinely important. Now, before I give you the exact questions to ask your doctor, there are 3 common mistakes that make medication timing even worse than it already is. Even if your medication timing is reasonable, 3 common habits can sabotage its effectiveness. Saboteur number 1: taking your medication with the wrong food. Grapefruit and grapefruit juice are well known for interacting with calcium channel blockers like amlodipine and felodipine. The compounds in grapefruit inhibit an enzyme called CYP3A4 in your gut that metabolizes these drugs. The result is dramatically higher drug levels in your bloodstream than intended. This can cause dangerous blood pressure drops, dizziness, and fainting. But here's one most people don't know. High-fat meals can significantly delay the absorption of certain blood pressure medications, shifting their peak effectiveness window by 1 to 2 hours. If your timing is already suboptimal, a fatty breakfast can push your medication's peak even further away from when you need it. The MediGentle solution. Take blood pressure medication with a small glass of room temperature water on an empty or light stomach. Consistent conditions. Same time. Same way. Every day. Saboteur number 2. Irregular timing. Your body's circadian system adapts to regular patterns. When you take your medication at 7 a.m. one day, 10 a.m. the next, and 8 a.m. the day after, your body never establishes a consistent protective rhythm. Blood pressure control fluctuates unpredictably. A study in the journal Chronobiology International found that consistent medication timing, regardless of whether it was morning or evening, was associated with better blood pressure control than irregular timing. The MediGentle solution. Set an alarm. Same time every single day. Non-negotiable. Consistency of timing may matter as much as the timing itself. Saboteur number 3. Splitting doses without medical guidance. Some patients, after reading about nighttime blood pressure, decide on their own to split their morning dose, taking half in the morning and half at night. This is potentially dangerous. Many blood pressure medications are formulated as extended-release tablets designed to deliver a specific amount over a specific time frame. Splitting them can destroy that controlled release and cause unpredictable blood levels. Never adjust your medication dosing or timing without your doctor's explicit guidance. This conversation must happen with your physician, not alone. Here is exactly what I want you to bring to your next doctor's appointment. 5 specific questions. Print them. Write them on a card. Put them in your phone. Do not leave that appointment without asking these. Question 1. Doctor, has my blood pressure ever been measured during nighttime hours? Do we know what happens to my blood pressure while I sleep? If the answer is no, ask about a 24-hour ambulatory blood pressure monitor. This is the gold standard for understanding your complete blood pressure profile. It's a simple device you wear for one day, and the information it provides is incomparably more valuable than any office reading. Question 2. Am I a dipper or a non-dipper? Does my blood pressure drop appropriately during sleep? This question alone will tell your doctor you understand the circadian rhythm of blood pressure. Most patients never ask this. Your doctor will likely be impressed and take the conversation seriously. Question 3. Based on my specific blood pressure pattern, would I benefit from taking any of my medications at bedtime instead of the morning? This opens the door to the chronotherapy conversation without demanding a change. You're asking for their clinical judgment, not telling them what to do. Question 4. Are any of my blood pressure medications specifically suited for bedtime dosing based on their pharmacokinetics? Some medications are better candidates for bedtime dosing than others. Non-dihydropyridine calcium channel blockers, certain ACE inhibitors, and some ARBs have evidence supporting bedtime administration. Your doctor can evaluate whether your specific medications qualify. Question 5. Can we do a 24-hour blood pressure monitoring test so we can make decisions based on my complete profile rather than just office readings? This is the most important question on the list, because without 24-hour data, every decision about timing is based on incomplete information. You deserve the full picture. Print these 5 questions. Take them with you. This is how you become an active partner in your cardiovascular care rather than a passive recipient of prescriptions. While you wait for that doctor's appointment, here's your MediGentle home monitoring protocol that will give your physician valuable data. Morning reading. Take your blood pressure immediately upon waking, before getting out of bed if possible, before taking your medication, before coffee, before anything. This captures your unprotected morning baseline. Afternoon reading. Take a second reading between 1 p.m. and 3 p.m. This captures your medication's approximate peak effectiveness window. Evening reading. Take a third reading 30 minutes before bed. This shows where your protection stands as you enter the nighttime hours. Record all 3 readings every day for 2 weeks. Note the time of each reading and when you took your medication. When you bring this log to your doctor alongside those 5 questions, you're not arriving as a patient asking for help. You're arriving as a partner presenting data. Your doctor will have more information in that 2-week log than they would get from 10 standard office visits. This is what MediGentle means by gentle empowerment. Not replacing your doctor, equipping you to work with them more effectively. Let me close the stories I opened. Leonard, the man who had a mini stroke at 3 a.m. despite taking his medication every morning for 9 years, worked with his cardiologist to move one of his blood pressure medications to bedtime. His 24-hour ambulatory monitoring 3 months later showed a dramatically improved nocturnal profile. His nighttime blood pressure, which had been surging uncontrolled, was now dipping normally for the first time in years. He cried during that appointment. Not from sadness, from relief. Barbara, whose morning headaches were dismissed as tension for years, also shifted her medication timing under her doctor's supervision. Her early morning blood pressure dropped from 162/96 to 134/82. Her headaches disappeared within 2 weeks. Same medications, same doses, different time of day. Neither Leonard nor Barbara changed their own medication. They brought information to their doctors. They asked specific questions. They requested 24-hour monitoring. And their doctors, armed with better data, made better decisions. That's the model. Knowledge plus partnership, not self-treatment. Every night, millions of seniors go to sleep trusting that the pill they took 12 hours ago is still protecting them. For many, it is. But for a significant number, the protection has worn off. And the most dangerous hours are approaching unguarded. You now know something most people don't. Blood pressure has a rhythm. Medications have a timeline. And when those 2 things don't align, a gap opens up. A silent, invisible, unmeasured gap where heart attacks and strokes are most likely to happen. You can close that gap. Not by changing your medication yourself, by having one informed conversation with your doctor. 5 questions, 2 weeks of home monitoring data. That's all it takes to find out whether you're protected when it matters most. Which of the 5 warning signs applied to you? Tell me in the comments. I read every single one, and I'll do my best to respond. If someone you love takes blood pressure medication every morning without ever questioning the timing, share this video with them. This could be the most important 19 minutes they spend this year. Hit subscribe and turn on notifications so you never miss a MediGentle conversation. Take care of your heart. Every hour. Even the ones you sleep through. I'll see you in the next one.